Dear ladies and gentlemen, dear colleagues, dear friends all over the world, we have attendance to this webinar in more than 30 countries. So this is an important event, especially considering that during the time of COVID, face-to-face meetings mostly have not been possible for the recent about 3 years. This event, presented in English, will be simultaneously translated in Mandarin, Spanish, Portuguese, and Russian. You can select the language by clicking on the interpretation widget you will find in your Zoom panel. This is a webinar organized by EMAS, sponsored by Abbott Company. So we would like to thank Abbott Company for their financial support. The program and the content are solely the responsibility of EMAS, the European Menopause and Andropause Society. The webinar will be recorded and it will be accessible on the EMAS website. The speaker of this webinar will be Professor Rong Chen from the Peking Union Medical College Hospital in China. The title of her presentation is Progestogen Choice in MHT and the Balance between Endometrial and Breast Safety. I'm very honored to be the chair of this event. My name is Alfred Mück. I'm a professor of endocrinology and also of clinical pharmacology. Since 25 years working at the University Women's Hospital in Tübingen, Germany, and part-time since about 10 years working also in China in the Capital Medical University as an honorary director in the Beijing Obstetric Gynecology Hospital affiliated to the Capital Medical University. So I will send my special greetings also to China. Some technical issues before we start. The webinar is on listen-only mode, means that your microphone is not working. Q&A session will be after the presentation. If you have questions, you can put them as text via the Q&A widget located in your Zoom panel. Now, I'm very delighted to have the pleasure to introduce our speaker, Professor Chen. I know Professor Chen already for many years. I would say from the start of her great career, 12 years ago, she was for a one-year postdoctoral scholarship working in my laboratory at our university in Tübingen, Germany. With her great help, we started our breast cancer project, which up from this time got many awards and international publications. So Professor Chen not only is a clinical expert in terms of the topic of her presentation today, but has worked also extensively in the research of breast cancer. Now, as we today know, the risk of breast cancer is mainly derived from the progestogen component of MHT. But on the other side, we need the progestogen together with the estrogen to avoid the risk of endometrial cancer. Professor Chen will give us advice how to get the balance between these two very different issues. To give a short introduction of her CV, she's a clinical professor in the Department of Obstetrics and Gynecology at the Peking Union Medical College College Hospital and also Deputy Director of the Gynecology and Reproductive Center. Within this center, heading a special unit, Center for Menopausal Diseases and Treatment. He is Vice President of the Chinese Menopause Society, President of the Climacteric Training in China Medicine Education Association, and also Vice President of this association. He is a long-standing member of EMAS and IMS, and she is and was primary investigator of several projects, including of the Natural Science Foundation of China. He published more than 100 academic papers. 尊敬的陈荣教授，我很高兴再次见到您。亲爱的陈，我非常期待你的讲座。请现在开始你的演讲。 Dear Rong Chen, please now start your presentation.
Thank you, Professor Milk, for your wonderful introduction. You are our older friends for all Chinese menopause doctors. Okay, now I'll start my presentation. Good evening, ladies and gentlemen. Thanks for joining me for this lecture. My topic is about progestogen selection, the balance between breast cancer risk and endometrial safety. First, I will introduce the history of menopause hormone therapy briefly. Then we'll discuss the risk of breast cancer and endometrial cancer with MHT respectively. Then we'll get our conclusion about progestogen selection for optimization of MHT. The depletion of or nearly depletion of follicles in the ovaries, resulting in low estrogen levels, is the basic reason of menopause-related problems, including recent symptoms and long-term degenerative diseases. In order to solve the menopause-related problems, menopausal hormone therapy, MHT, came into being. What's the problem? Okay. It works. Okay. All the guidelines recommended MHT as the most effective treatment for relief of menopause-related symptoms. Although the efficacy of MHT is beyond doubt, the development course of MHT was still very bumpy, mainly because of the side effects. In the history, endometrial cancer risk related to estrogen only caused the first big drop of MHT. Since the addition of progestogen, endometrial cancer no longer seems to be the risk of MHT, but the concern about the risk of breast cancer and CVD risk caused by the publication of WHI results the second decline of MHT. Now, we all know breast cancer risk is mainly related to progestogen used in MHT. Progesterone or digesterone do not increase breast cancer. But in recent years, some articles showed the risk of endometrial cancer of MHT again, mostly related to natural progesterone. So, how to choose estrogen and progestogen? It's so complicated. Let's summarize it briefly. No progesterone increased endometrial cancer. With progesterone increased breast cancer, at least some kinds of progesterone. How to balance the risk of breast cancer and endometrial safety? How to provide a safe MHT? It seems the most important thing is progestogen selection. Okay. Let's move to the second part. Risk of breast cancer with MHT and its solution. Breast cancer is the highest threat to middle-aged women's health. The relation between MHT and the risk of breast cancer has become the focus of attention within the field of menopause in the past 20 years. several important articles on MHT and breast cancer risk, published successfully in 2019 and 2020 in good magazines, including Lancet, JAMA, and BMJ. Here's some possible mechanisms of progestogen increasing breast cancer risk. Progestogen regulates memory cell proliferation by inducing rancor system. MPA induces a large amount of rancor, leading to massive proliferation of memory epithelial cells. Cell division increases and the DNA areas accumulate, eventually leading to breast cancer or the proliferation of more malignant cells. There are many kinds of progestogen, which can be divided into two categories, natural and synthetic. But digesterone is a special synthetic progestogen, also known as neuroprogestogen, which combine to progestogen receptor only. So digesterone could be listed apart from other synthetic progestogen. Now come to the question. Do all progestions increase breast cancer risk? This slide showed the results of WHI with 20 years follow-up, which published in 2020. From this figure, we can see CEE plus MPA increased breast cancer risk, but CE only decreased the breast cancer incidence. Okay, the results showed on this slide were from E3N retrospective cohort study. In this study, oral estrogen was used with different progestions. With more than 8 years of MHT, the risk of breast cancer with digesterone was lower than other synthetic progestions when MHT was taken orally. Now, let's look at the lab data. In vitro test, estradiol plus dihydrogesterone makes breast cancer cells apoptosis higher than proliferation. Tibolone also showed similar results, but other synthetic progestogens with oral estradiol caused breast cancer cells a proliferation-dominated change. The effect of natural progesterone is neutral. In 2020, this article was published on BMJ. The objective was to assess the risk of breast cancer associated with different types and durations of HRT. Participants were nearly 100,000 midlife women with a primary diagnosis of breast cancer and matched controls. The risk associated with HRT increased with duration of use, but the associations was less strong for estrogen-only therapy and for tibolone than for estrogen progestogen therapy, apart from estradiol dihydrogesterone preparations. Loresisterone, levonorgestrel, and MPA were associated with similar risks, increasing across all duration categories longer than 1 year. For all exposure durations, the combined treatment with the lowest associated risk was estradiol dihydrogesterone. Estradiol dihydrogesterone combined does not increase the risk of breast cancer in patients of different ages subgroups, also in different BMI subgroups. Here's a description about the risk of breast cancer and MHT in 2016 IMS recommendations on women's midlife health and MHT. The risk of breast cancer attributable to MHT is small, and the risk decreases progressively after treatment is stopped. The increased risk of breast cancer is primarily associated with the addition of a synthetic progestogen to estrogen therapy and related to the duration of use. The risk may be lower with micronized progesterone or dihydrogesterone than with a synthetic progestogen. Now, let's back to the picture. When we choose a progesterone preferred to reduce breast cancer risk, we should choose natural progesterone and dihydrogesterone. This cycle should be drawn on the left. Low dose should be preferred. Okay, now let's move to the third part. Risk of endometrial cancer with MHT and its solution. Estradiol is the main factor to induce proliferation of the endometrial glands, stroma, and vessels. Progesterone antagonized the proliferative effect of estradiol. Hyperplasia results from the constant stimulation by estradiol in the absence of progesterone, or in condition of excess of estradiol. Progestin are able to reverse hyperplasia and to generate atrophic endometrium. The concept of the importance of estradiol-progesterone balance is crucial to respect the endometrial safety. With the long-term estrogen without a progestogen antagonism, the endometrium may proliferate and even become cancerous. Estrogen-only therapy increases the risk of endometrial cancer in relation to estrogen dose and duration of use. In a recent large cohort study in Sweden, to examine the association between the incidence of various cancers and the MHT, the endometrial cancer subgroup study found that the risk ratio for endometrial cancer among women on estrogen progestin supplication was 1.07, 95% CI including 1. That means no significance. With the increased risk only limited to patients 70 years of age or older. Now, this picture, come again. Similar question will be asked. Are all progestogens equally safe for the endometrium? This slide showed the effect of different progestogens in MHT on endometrial cancer risk from the E3N study. Estrogen plus dydrogesterone showed no risk of endometrial cancer, but estrogen plus micronized progesterone increased the risk of endometrial cancer. And the difference was significant. Here are results from EPIC study with more women with average 9 years of MHT. The picture showed micronized progesterone increase the risk of endometrial cancer, HR more than 2. This table was from a paper published in 2016, which was a review about endometrial cancer risk by progesterone type. E3N, EPIC, and several other similar research were included. EPIC, E3N, EPIC. Yeah. The review found endometrial cancer risk were different with progestogen types, which was increased with micronized progesterone, and no increase was found in synthetic progestin. Tibolone is an MHT medicine commonly used in China. The slide showed endometrial cancer risk among former, current, and non-users of Tibolone. This table is also from the review. The authors showed Tibolone increased the endometrial cancer risk. The risk will further increase with the longer use time, but the risk will decrease after discontinuation. Why? Lab research may provide some explanation. The efficacy of transforming endometrium varies greatly among different progestogens. Oral administration of 10 mg or 20 mg digesterone achieves a higher progestational potential, reaches an optimal morphology of endometrium, nearly totally transforms of the endometrium. But oral administration of microprogesterone, 20 mg daily, only got 6% of the gross morphology score. Even with the daily dose of 300 mg, the gross morphology scores was about 75, still lower than that by digesterone 10 mg daily. The postmenopausal estrogen progestogen intervention, also called the PPI trial, was a randomized controlled trial. Midlife women were assigned to 5 groups. They all have intact uterus. They were given placebo, CE only, CE plus MPA, cycling and continuous or continuously, CE plus MP for totally 3 years. The results showed that estrogen alone was associated with an increased risk of endometrial hyperplasia. Although CE plus MPA or MP, the endometrial hyplasia was threat was borderline. There was no increased risk of endometrial in the sequential and continuous EPT groups. Low endometrial cancer occurred within 3 years, within the 3 years. Now we're back to the review. The authors further compared the effects of different protocol EPT on endometrial cancer. In the same study, the endometrial cancer risk of sequential regimen was always greater than that of continuous combination regimen. Does this mean that the endometrial safety of continuous of sequential regimen is not so good? No, we cannot say this like this. Yeah, this article published in 1997 reveals that the risk of endometrial cancer differs with the duration of progesterone use per month. If the progestogen application days per cycle is less than 10 days, the risk of endometrial cancer was indeed increased. But if the number of the progesterone days is more than 10 days per cycle, the risk of endometrial cancer is not significantly increased. Okay. A meta-analysis published in 2014 further proved that the relative risk of endometrial cancer was significantly lower for progestogen use for 10 days or more per month than for progestogen use for less than 10 days. What's the impact of treatment duration on endometrial cancer risk? Oh, there. It's still unclear and may increase with time. The authors of the review concluded that use of unopposed estrogen, tibolone, and sequential combined therapy, I think should add progesterone less than 10 days per month, increases the risk of endometrial cancer. Continuous combined therapy seems risk-free, but possibly not when macronized progesterone is used. So it's not confirmed that MHT does not increase endometrial cancer. It depends on regimen, progestogen type, and dose. Here again, the picture. When we choose a progestogen preferred to reduce endometrial cancer risk, we should choose synthetic progestogen or digesterone. This cycle should be drawn on the right. High dose should be preferred. Why can't micronized progesterone provide enough protection for endometrium? It may be related to low bioavailability and low efficacy of membrane transformation of progesterone. Progesterone needs a higher dose than the currently commonly used dose to protect the endometrium adequately. the metabolites of progesterone will bind to the GABA receptor, resulting in some physical discomfort, which limits the increase of the daily dose of progesterone. So that's the reason we can't increase the dose of progesterone. Now we come to the last session. Progesterone selection for optimization of MHT, breast cancer and the endometrial cancer risk to balance. Here is the description in IMS guideline about the risk of breast cancer and also the endometrial cancer risk. I think I still have time. I should read it. The increased risk of breast cancer is primarily associated with the addition of a synthetic progesterone to estrogen therapy and related to the duration of use. The risk may be lower with micronized progesterone or diprogesterone than with a synthetic progesterone. Higher doses of progesterone may be required for endometrial protection when higher doses of estradiol are used, or in women with higher BMI. Unopposed estrogen therapy is associated with a duration and dose-related increase in risk of endometrial hyperplasia and cancer. Endometrial protection requires an adequate dose and duration of progesterone. Okay. Here are the descriptions from IMS, NAMS, and also from Chinese Medical Association guidelines. The key points are similar. Progesterone or diprogesterone is recommended for MHT. Progesterone dose needs to match estrogen dose. That's the key points. Oh. Let's review the star picture in my speech again. Considering breast cancer risk, progesterone and diprogesterone are preferred to be used in MHT with relatively low dose. Considering the endometrial cancer risk, diprogesterone and other synthetic progesterones with relative high dose are recommended. So diprogesterone is the most suitable choice for adequate protection for the endometrium and mammary gland at the same time. Comprehensive evaluation of benefits or risks and comprehensive optimize of regimen, medicine types, and doses should be used. We should try to balancing the endometrial safety and the breast cancer risk. I want at the last of my before I close my presentation, I still want to clarify. Although I have said a lot in favor of in favor of digesterone today. I do not mean that other progestins are useless. I just think it's digesterone is very lucky because they have the good progesterone type, and they also find a suitable dosage for MHT. If we choose natural progesterone for MHT in MHT, we need to continue our efforts in the pharmaceutical process and try to improve the effective dose and to decrease the side effects. If the dose of synthetic progesterone is carefully titrated, perhaps a reasonable dose which can fully protect the endometrium without increasing the risk of breast cancer can also be found. But now only digesterone has the suitable dosage. Although MHT has a more bumpy course than most other treatments on the world, we are confident, at least I'm confident, that we can provide optimized MHT after comprehensive evaluation of benefits and all risk. And we can optimize of regimens, medicine types, and doses. Okay, thank you for your attention. I'm so nervous. Thank you.
Okay, I want first thank you, Professor Chen, for your excellent overview on a difficult topic. This topic is, in my view, the most important one in the field of MHT. You have given us the clinical studies and also the experimental research, and also the most important international guidelines covering the question about the choice of the progestogen in MHT. We now will start the Q&A session. As I already told during the start of the webinar, your microphone, the microphone of the audience, is not working. However, if you have any questions, you can put them as text in the Q&A widget. It is located in your Zoom panel. The questions will be answered by Professor Chen or by myself as they come in one by one. Maybe it is good that you identify yourself with your name and briefly give your institution and country where you come from. I can start because I can see that there is a question in this Q&A session coming in from Argentina. And the question is that in Argentina, they do not have progesterone. And the question is, they want to use a micronized progesterone, and they use it for 10 to 12 days together with estradiol percutaneously, that is with gel. And the question is to us what we do think about this theme. Professor Chen, you want to answer this question? The question to progesterone together with gel, if you have experience about this. If not, I can also answer the question.
Yeah, actually in China, we don't have much experience using
the progesterone.
Yeah, we have some experience about of the micronized progesterone, but we have more experience about use of digesterone. Sometimes I also use micronized progesterone plus estradiol percutaneous, especially for those women with a higher risk of DVT or something like this for elder women.
I would add that I have experience with testosterone working in China and also with progesterone working in Germany. I use the progesterone. I like it in women who have problems with sleep. Giving progesterone orally in the evening, it can induce can treat sleeplessness. And it is also, as Professor Chen said, very neutral in the cardiovascular system. Although I can say testosterone also is very neutral in the cardiovascular system. I have published about this in climacteric and in gynecological endocrinology with own research. So both progestogens are very neutral. Regarding the question, I would, I confess that I use the micronized progesterone orally for 14 days, not for 10 to 12 days. But sometimes the doctors do not like it because it is, of course, more expensive. But I use it 2 weeks, the estrogen gel only, and 2 weeks together with progesterone in the evening, or I use it also every day, the progesterone. So the next question is about vaginal use of progesterone. And here, first again, my question to you, Rong Chen. I do know that vaginal progesterone is not really used by us in China. Have you any experience with the use of progesterone, even vaginally? And this is one of the next questions.
Yeah, we don't have much experience use progesterone vaginally. And I think in general, Chinese women do not like the vaginal application form, at least not in long-term MHT. Sometimes we use progesterone vaginally when we ART, IVFET. Yeah. And also in China, we have several products of micronized progesterone, some in capsule, which could not be used vaginally, some in gelatin pearl, which could be used in vaginally. Yeah. And maybe Professor Milk, could you share your experience?
As I told you, we use it in Germany, also vaginally, because there is a systematic review by Stute et al. Published in Climacteric that the vaginal use of progesterone has a better risk profile regarding endometrial cancer. And as I know, until now, there has been no studies with increased risk of endometrial cancer using progesterone vaginally. But it is also my experience in our hospital in China that we have not women who have only few women who like it. But in Germany, we can do it, and it is indeed a good tool to reduce the risk of endometrial cancer with progesterone, which has been here given in the talk of Professor Chen. And now this this comes to the next question. The first question here was vaginal use. Can it reduce the risk of endometrial cancer? The answer is yes, according to the present data. It is because there is a higher dosage of progesterone in the endometrium if you give it vaginally. Now, the next question is in a similar direction: how to reduce risks with other application forms. And the question is, what about levonorgestrel containing in an IUD? You are laughing. The question is very often given to reduce breast cancer risk. Do you like, Professor Chen, to answer on this. It is to give Mirena together with a gel to reduce the risk of breast cancer. What is your opinion about this?
I read
important question.
Yeah, it's a very important question. I read I think 2 articles about the relationship of Mirena and breast cancer. It's good for health women to especially for the perimenopause women with AUB, but more than 2 Mirena may increase the health woman the breast cancer risk, and if for those women already or we call the breast cancer survivors, Mirena is not so safe for them.
The next question is the same. There are several questions about Mirena. The question is from Armenia. Using Mirena together with transdermal estradiol, especially during perimenopause. And as Professor Chen already said, it is not totally clear if Mirena really can reduce the risk of breast cancer, at least if it is used twice for 10 years. There are at least 2 studies showing an increased risk of breast cancer. So I would agree with Professor Chen that we have controversial data about the risk of breast cancer with Mirena. But given the fact that the dosage of progesterone, the dosage of the progestogen released from Mirena is very low, the levonorgestrel levels are very low. So I would think that the risk of breast cancer using Mirena is really very low. So I think this is a good regimen, but it is out of label. So we have to say to the patient that this is a regimen which is not introduced in the labeling. But you can do it, and you have also a contraception during perimenopause. And this is an option with Mirena. I have another question. Do you think that it is wrong that dydrogesterone alone is not available in UK? The question is, of course, from UK. So they have not dydrogesterone. Do you think they need it? Is it? I think, Professor Chen, you would say yes, in your opinion. No?
Yeah. Yeah. Thanks, Dr. Alice from UK. I can read the question. Yeah. You don't have dydrogesterone as a standard alone medication in the UK, but I think if you have the compound, I think you mean you have the compound preparation with dydrogesterone. I think for the perimenopause women or the early postmenopause women, the compound preparations is a very convenient treatment. Yeah. If you, when we the next part, how to adjust the dose of micronized progesterone. Actually for CCHRT, 1 milligram of MP is I think it's good. And for the sequential therapy, we could use 20 or not 20, 200 or 200 from 200 to 300 milligram at night for 14 nights out of 25. It's good. For women more with a BMI more than 30, we should increase we should use stronger progesterone to protect their endometrium. For this woman, I would like to use hydrogesterone. Preferred instead of progesterone.
I think Rong Chen is a really good answer to the long question of Alice Duffy from UK. So sequential should given 200 milligram at least, maybe even 300 milligram. I would recommend 14 days, and continuous combined, you can use 100 milligram given at night. And your question about BMI in obese women, I agree that we should give a higher dosage of progesterone because these women are at higher risk for endometrial cancer. Another question here was, do you think that tibolone is secure? How do you think about tibolone use in South American is often used? What is with tibolone in the cardiovascular field? I think cardiovascular is not the topic today. Just to say tibolone regarding breast cancer and endometrial cancer, this was in the presentation of Rong Chen, and she presented, and the chart was that tibolone has an increased risk of breast cancer in some studies, like Million Women study. But there is also another study, the TEBES. It is a placebo-controlled study. There was no increased risk. So I would say the risk of endometrial cancer with tibolone is there, according to the slides of Professor Chen. And there is also maybe a risk of breast cancer, which might be lower than compared to other MHT. Do you agree with this, Chen?
Yes, I totally agree with you.
Then there is the next question about continuous estrogen combined with micronose progesterone every day or 25 days per month. So it is about continuous combined use. I remember there was one slide in a study with the conclusion that continuous use of progesterone may increase the risk of endometrial cancer. It was in one slide of Professor Rong Chen. I would add that very recently there have been a study called Replenish study. It is a placebo-controlled study where they give the micronized progesterone every day for 1 year, and there was no increased risk of hyperplasia. So we need more data because the evidence with micronized progesterone is controversial. But I have, when I use the progesterone, I very carefully check the endometrium every 3 months by vaginal ultrasound, and also look carefully at the bleeding patterns. Because for me, no doubt, we have more problems with the endometrium, even the progesterone. This is like was in the presentation of Rong Chen. So this would be the answer of this question. Now I'm looking if there are more questions about this.
No. Lot of questions. Yeah. Oh, we have so many questions.
But we have put together some questions. One is about transdermal estradiol together with dydrogesterone. I do it, of course. Transdermal estradiol can reduce the cardiovascular risks. It's a very important application form. Transdermal estradiol can reduce the risk of venous thrombosis. So we can add to transdermal estradiol the micronized progesterone, or if we want to have a more endometrial safety, we can also add the dydrogesterone. Is also your view, Rong Chen? I think so. Transdermal estradiol freely combined with dydrogesterone. But some countries do not have the dydrogesterone, so they have to combine with a micronized progesterone. So this we have also answered. Another question would be about the, maybe you can answer this, Rong Chen. Give us the dosages of estradiol and dydrogesterone when you use it sequentially and when you use it continuously. What are the dosages? Until now,
Oh,
we
okay.
have it not in the lecture.
Okay. Usually, when we use the, I will suggest 10 milligrams, 10 milligrams digesterone daily dose for sequential regimen, and 5 milligram digesterone for continuous combined regimen. And for older women, after long maybe 5 years or longer time after menopause, we could use lower dosage of estrogen and progestogen. In China, I think we do a lab about new ultra dose pharmaceuticals we call the pharmaceuticals mini, which can containing 0.5 estradiol plus 2.5 milligram digesterone. Yes,
yes, it is new in China, and in some countries we have the so-called mini hemostone, which is very low dosage, 1 milligram estradiol continuously combined with 0.5 milligram. Now there are no longer questions in Q&A, so I want to make a very short summary of this webinar. Progestogens primarily are needed in MHT to reduce or avoid the risk of estrogen-induced endometrial cancer. For hysterectomized women, the addition of any progestogen is not needed. However, progestogens are mainly responsible for the increased risk of breast cancer. So the choice of the progestogen primarily is according endometrial and breast safety. With all synthetic progestogens, in my view, we can get endometrial safety provided adequate dosage and addition to the estrogen at least for 12 to 14 days per cycle. However, all synthetic progestogens, in my view, increase the risk of breast cancer. This is dependent on the duration of MHT. The risk is mostly seen after 5 years, and the breast cancer risk is higher using sequential MHT compared to daily combined MHT. Even we need more studies about this question. There is an exception with the use of dydrogesterone, which indeed, from the chemical view, is a synthetic progestogen, but dydrogesterone is more neutral because it is the retroisomer of progesterone. So with the use of dydrogesterone, we get endometrial safety and at least for 5 to 8 years also breast safety. And we know also that with progesterone, we have studies like the PEPI study for sequential use and replenish study for continuous use, that also with progesterone, there was no increased risk of endometrial hyperplasia, but that evidence is controversial and we need more data and should more carefully also monitoring when we use the progesterone. I can add that in certain patients, or I also use special synthetic progestogens. So we are happy to have many progestogens and can individualize our treatment. For example, I use anti-androgenic progestogens in hyperandrogenic situations like PCOS or special type of diabetes or metabolic syndrome. This also was a question that's now coming in So in metabolic syndrome, I use the progesterone or testosterone, or I use oral estrogen, which can increase SHBG, which is good in metabolic syndrome because of the hyperandrogenemia. And I combine with an anti-androgenic synthetic progestogen like drospirenone or dydrogenogest. So this question exactly brings us to the fact that we are happy to have many different progestogens so we can individualize the therapy. This also was said by Rong Chen at the end. My great thanks to Professor Chen, the thanks to the organizers of EMAS, to the agency responsible for the logistic of this webinar, and to Abbott Company for financial support. 现在研讨会结束，谢谢大家，再见。This is the end of this webinar. Goodbye. Goodbye.
Thank you. Thank you, Professor Milk.